Hey guys, so our SWOT analysis is on the acute effects of blood flow restriction at various limb occlusion pressures on muscle activation and single leg static balance in healthy adults. So for our subject pool, we originally started with the idea of getting 80 and we were able to get 92. So that's 23 subjects per group. We have 4 different levels of occlusion pressure, 20%, 40, 60, and 80%. And for our sampling, we were able to get these patients through word of mouth, through Sonos subject pools. We use our fellow DPT students. We used family and friends. And for assignment, we used consecutive assignment. For our inclusion criteria, we had adults aged 18 to 35, and they had to be right-sided leg dominance. And for our exclusion criteria, they could not have any previous knee surgeries, any lower extremity trauma, no knee pain or back pain within the last 6 months. They could not have an allergy to shaving cream or the EMG adhesives. They could not have any vascular compromises, no clotting disorders, or other elevated risk of some type of embolism, no renal compromises, and they could not have hypertension. So prior to our methods, we had the patients sign 2 documents, and after they finished the entire research, we had them sign another document. And once we were in the methods, we had to try to do a 1 repetition max. So with this, we used a hydraulic push-pull dynamometer, which was used to measure the max isometric knee extension contraction force. So for this, the subjects were seated with their hips and their knees flexed to 90 degrees. We used a belt that was wrapped around the table, and then it was wrapped around the table and their right ankle, which covered their right and lateral malleolus. The dynamometer was placed on top of the mulligan belt, and then the subject kicked with maximal effort for 3 seconds. And we did that total of 3 trials, and we took the average of that. And then for the EMG surface electrodes that we use specifically the LICs, and we placed them on the VMO and also the VL, the vastus lateralis. And the reason we did that was to measure muscle activity during exercise and balance testing. So the EMG placement was a reference line that we used that went from their ASIS to the center of their right patella. And from that right line, we went to the patient's left around 50 degrees, exactly 50 degrees, and then we went 4 centimeters up, and that was their VMO placement. And then using that same line again, we went to the patient's right, exactly 15 angles and 10 centimeters up, and that was a placement for the vastus lateralis EMG.
For our baseline balance testing, we performed the balance testing on the Biodex BioSway balance machine. So we measured their single leg stance on their right leg. This was done on a firm surface, and we had their eyes open while completing this. So we did 3 20-second trials, and the balance was measured in overall postural sway, anterior and posterior stability, and medial and lateral stability as well. So to calculate the subject's limb occlusion pressures, they were instructed to rest supine for 5 minutes prior to the H+ BFR cuff being applied to their proximal thigh. The cuffs were placed at 3/4 the distance between the superior border of the patella and the right ASIS. The BFR cuff was inflated while we had a handheld Doppler at the right posterior tibialis artery at a 45-degree angle to assess when blood flow was fully occluded. As far as the exercise that we did short arc quad with the BFR, of course. And like Milton said before, the cuffs were inflated to 20, 40, 60, and 80% of limb occlusion pressure, depending on the group. They performed the short arc quad exercise with an ankle weight equivalent to 30% of their 1 rep max. Total of 75 repetitions were completed over 4 sets, broken up into 1 set of 30 repetitions, and then 3 sets of 15 following that. Patients had a 1-minute break in between sets, and the balance task on the BioSway was repeated immediately after the exercise.
So now moving into the SWOT analysis portion of this presentation. So for the strains, one of them was the study design. We completed a single blind randomized control trial where the subject did not know what group they were in. Then we also had a large sample size. We were able to collect 92 subjects, again, each with 23 subjects in each group. We had internal consistency, so standardized protocols, and each member completed the same task for each trial. We have a variety of outcome measures that we assess, so both varying from subjective outcome measures to objective measures. And then we also use highly reliable and valid instruments consisting of the hydraulic push-pull dynamometer, the Biodex BioSway balance machine, and the DeLisse's EMG sensors. Moving on to the weaknesses of our project. So when subjects were completing the balance portion, they sometimes completed at varying knee flexion angles. So they were instructed to balance with their knees slightly bent. However, we did not measure the knee bend for each subject in each trial. So there was a little bit of variation in between trials for each individual subject, and then variation between the subjects as well. Another weakness was the variable timing between completing the BFR and then assessing the patient's balance. So it took a various amount of time to take off the BFR cuff and the ankle weights. And that time varied between patients because some subjects had more ankle weights, some subjects had less. So this impacted how quickly the subjects could go to the Biodex machine after completing the exercise. We only completed a single session assessment. So We only analyzed balance immediately after the exercise. We didn't do it 2 minutes after, 5 minutes after, so we don't know the duration of the effects that we saw. And then also the last weakness that we noted was the 1 rep max testing position. So we wanted to test for a knee extension 1 rep max. However, when we were testing for it, we completed knee extension 1 rep max testing in the seated position with their hips and knees at 90. However, the exercise we performed was in supine and at a different knee flexion angle, so that could potentially alter their 1 rep max for that specific exercise.
Okay, so some of the opportunities included the ability to determine whether exercising with BFR is an effective intervention for improving balance and increasing muscle activity. Some opportunities for future studies include examining the effects of BFR application while they're performing the balance tasks on balance performance and muscle activity at that time. Also, for future studies, we can also conduct the research on clinical populations, including older adults or post-surgical patients. And there's also potential to inform physical therapy clinicians about the benefits of BFR beyond the traditional hypertrophy effects. So some threats in our research include the Hawthorne effect, potential test-retest bias due to practice effects, and which is potential for improved performance during second balance assessment due to task familiarity rather than true intervention effects. The setting, so characteristics of the study setting may limit generalizability to other environments. Balance was assessed in a quiet room with no distractions, and the lack of generalizability to other populations. Because the subjects were only healthy adults from 18 to 35 years old, it is difficult to say that this will work for other populations. Thank you very much. We grant permission for this video to be used as course material for the Research 1 course.